Discussing prognosis and end-of-life care issues is often difficult. It requires effective communication between health professionals and families and a framework for it to be successful. Many of us feel uncomfortable embarking on these discussions for many reasons. When we avoid these discussions, it can lead to poor patient satisfaction, increased psychosocial morbidities, and increased healthcare cost. Therefore, in the interest of the patients, that we embark on these discussions and help our patients plan their end-of-life care issues. This video is aimed at providing a framework for approaching end-of-life care discussions and issues. When we discuss end-of-life care issues, the following items need to be considered: the timing of the discussion, the discussing the prognosis itself, and the advanced care planning and end-of-life care arrangements.
A number of opportunities can exist in terms of timing for end-of-life care discussion. All patients with advanced progressive life-limiting illnesses should be given the opportunity to discuss prognosis, including life expectancy, how the illness may progress, future symptoms, and the effect on function and end-of-life issues. It is often preferable to make plans when patients are moving into an institution such as a nursing home. It's also important to raise the topic or introduce the topic in a number of circumstances. There are a number of times where it might be a little bit easier for the clinician to raise the issue of end-of-life care discussion. And the first would be when it's clear that the patient has a life-threatening or a progressive illness. Sometimes this is difficult to do on the first meeting with the patient, but sometimes there's 2 or 3 clinical consultations where the diagnosis is established, and it's important over that time frame to discuss end-of-life care. Sometimes the issue becomes important when there's an acute deterioration. Sometimes there's just a perception on the patient's part that things are getting worse, and that should be enough to trigger that discussion. The issues may be raised if the patient or relatives of the patient have expectations that aren't really quite correct or are not in line with the clinical judgment, and in that situation it becomes even more important to raise the issue of end-of-life care. So if disease-specific treatment is not working, or if there are complications from treatment, that can be another trigger where you can start to discuss these issues. Finally, the illness being an end-of-life illness will tend to slowly progress, and once symptoms become advanced, or if patients start to need frequent admissions to hospital, then those admissions might be a trigger for discussing end-of-life care.
So now I'm going to give you some examples where end-of-life care discussions would be appropriate. Consider an end-of-life care discussion for any patient who has multiple admissions to hospital within the last 6 months, any patients with metastatic cancer where life expectancy is short, for example lung cancer, patients with class 3 or 4 heart failure with a low ejection fraction who may have their ADLs limited by severe breathlessness, patients with COPD with an FEV1 of less than 1 litre or on home oxygen, patients with end-stage renal failure with multiple comorbidities, and any patients who have frailty or are very elderly. For example, patients with an unintentional weight loss or a low BMI, patients who are cognitively impaired or have a diagnosis of dementia, any patients who have poor mobility or multiple falls, and any patients with osteoporosis or on multiple medications. In addition, I always ask myself, would I be surprised if this person were to die within the next year? If I find that the answer is no, then the time for me to have an end-of-life care discussion with that person is definitely now.
Now that we have identified that end-of-life discussions are appropriate, we will discuss how to go about starting these discussions. In fact, what we're talking about is being prepared, and prepared is an acronym that has been used very widely to help us. First is P, we have to prepare for the discussion. The second letter is R, to relate to the person with whom we're having the discussions. Third is E, which is to elicit the patient's wishes and also those of their caregivers. Fourth letter is P, to provide information to the patient and to their family. A is to acknowledge emotions and also acknowledge concerns that the patient and their family may have. R is for realistic hope. E is to encourage questions. And D is to document and to debrief after we've had the conversation.
Today's case to illustrate our end-of-life care planning is Mr. Sim. He's a 74-year-old gentleman with idiopathic dilated cardiomyopathy, and he has end-stage renal failure on hemodialysis. His ejection fraction is 24% and he's on multiple medications. He is unable to enjoy activities of daily living and has very poor quality of life related to his illness. He ends up in hospital on almost a fortnightly basis to CCU, requiring CPAP and diuretic therapy. He was admitted this time 5 days ago and is now over his acute deterioration. He's comfortable at rest and planning for discharge.
John has severe cardiac dysfunction with other comorbidities like end-stage renal failure requiring dialysis. I do need to discuss end-of-life issues with him because his life expectancy is thought to be short. He is in a noisy 4-bed bay and has no family members with him. What I would do is move him to a quiet room and have his next of kin with me. It also helps to have other health professionals like nurses looking after him to go in with us. I will also take his chest X-ray along so that I can discuss it with John. Good morning, John. How are you today?
Thanks, doctor.
The nurses tell me you had a comfortable night last night.
Yes, I had a good night's sleep last night and I'm breathing well.
Is there anything we can do to make you feel more comfortable?
No, not really. I think we're on the right track.
You know what we are discussing today, John. We are discussing your heart function. And are you happy to go ahead with that discussion now?
Yes, that's fine.
You're not responding very well to treatment, and I'd like to discuss the options that you have. Is there anyone else you'd like to be on this discussion?
No, I think I'm fine.
All right, so we'll get started then. So as you can see on the chest X-ray, the lungs are filling up with fluid, and the CPAP treatment that we use tries and pushes the fluid out. Unfortunately, the medication is not working as well as it should, and that the kidneys are not working well means that the fluid is not being pumped out as it should normally be. Do you understand this?
Although I want to live forever, I'm not surprised by today's news.
The other part of this is the heart, when the heart is enlarged and not pumping well, there are chances of developing bad rhythms of the heart and even sudden cardiac death.
I'm not surprised, and thank you for your honesty.
So John, did you have an idea that you were losing ground?
I had a gut feeling, doctor.
Were you expecting news like this?
No, not really, but I have to deal with it in a positive way. So what can I expect?
Though we can't cure this condition, John, we will still find ways of helping you. Are you comfortable if I talk to the palliative care team and see if they can come in and give us a hand?
Don't they deal with dying people?
That's a misconception. They do help with symptom relief like pain or shortness of breath. They will help you live at home as long as possible, and all these things will improve your quality of life. So if you're comfortable, I might get them to come and see you before we discharge you home.
Okay, thank you, doctor.
At the core of current health care are the efforts to promote patient-centered care and person-centered care, also patient choice and autonomy. That is the patient's right to refuse and to consent to treatment. The trouble is with this is that if the patient loses the ability to make decisions or loses mental capacity, then this patient autonomy falls through. And to get around that, we should use advanced care planning. And this is the process where a healthcare professional will explore a patient's wishes, their thoughts and their values to see what treatments they would be accepting and what treatments they would want to avoid. So advanced care planning is a process of exploring the patient's wishes and thoughts about future treatments. Part of the advanced care planning is not only the exploration but also the documentation. And I want to go through 4 main end-of-life documents that I feel are useful in looking after a palliative care patient, for example. The first is the legal will. The legal will is a legal document that stipulates where the deceased person's assets and estate should be distributed. And I think it's worth having this because it decreases conflict in the family after the patient has died. The second document is the enduring power of attorney, and a patient who has mental capacity needs to nominate a person, whether it's a family member or a friend, to make medical decisions on their behalf should they lose their ability to make decisions and should they lose their mental capacity. And I think it's one of the most important things to do to allow the patient to have an advocate to help extend the patient's autonomy beyond when the patient loses capacity. The third document is that of an advanced health directive, and I feel that this is a lengthy, repetitive and onerous 21-page document that aims to distill the patient's wishes in certain different circumstances. So one situation would be a persistent vegetative state, and another would be a terminal phase of a incurable illness. And it asks the patient whether they would accept artificial hydration, artificial nutrition, life-prolonging treatments, and cardiopulmonary resuscitation should they have a cardiac arrest or a respiratory arrest. So I find that if a patient has done an advanced health directive, I find that it does give us useful information to guide further treatment. However, I find it quite onerous, and I think you need to get a lawyer and also medical input to develop the document. So if a patient hasn't completed it, then I wouldn't be encouraging them to do it. In its place, I use the acute resuscitation plan. Now, it's probably a misnomer because it's probably not completely about resuscitation. It's about patients' wishes. And I've got an example here for you. This is the acute resuscitation plan that we use. On the top we've got the place for patient label. Down here we've got patient's diagnosis and prognosis can be filled in here. Whether the patient has capacity, that's mental capacity to be involved in decision making. And here we've got 2 boxes. This is the treatments that the patient would be accepting, and this is the treatments that the patient would refuse to accept. So up here I'd be putting good palliative care, symptom management and end-of-life care. If there's conditions like cellulitis or urinary tract infection, then I'd encourage the patient to, or I'd suggest IV fluids and IV antibiotics would be sensible in this section. If the patient didn't want resuscitation, then I'd put not for CPR here. I'd also probably put ICU, not for ICU, and not for ventilation in this section. But it obviously depends on the patient's wishes and preferences. No enduring power of attorney or patient can ask for treatment that is futile or would not benefit them. So a patient who's got a terminal cancer and is imminently dying cannot ask for a life support machine. That would be futile and it wouldn't be in their best interests. Down the bottom is a tick box section, CPR, to provide or not to provide. And on the other side, it's got a section where you can actually write down the patient's thoughts and in their own words, which is ideal, and whether they've been involved in the discussion regarding the advanced care plan. We've got a tick box style to suggest whether there is an advanced health directive been made or whether there's an enduring power of attorney. If there is an enduring power of attorney for welfare, then the name should be put here as well as the phone number to allow easy access. And then there's a tick box portion here to suggest that this acute resuscitation plan is for this admission or until a certain date or for subsequent admissions. And for convenience, I usually put the for this admission and for subsequent admissions. And then there's just some signatures. On this side, there is an area where you can write down the patient's family, friends, and also healthcare staff that have been involved in the discussion. So ultimately, if we don't ask the patients or explore with the patients their wishes and their thoughts regarding future treatment, then we're liable to either overtreat or undertreat. However, with good advanced care planning, being proactive and knowing their wishes, then we can honour and respect their wishes going forward.
With increasing use of video conferencing technologies, many clinicians are expected to discuss end-of-life care discussions through this technology. While the concepts in the acronym PREPARED are the same as face-to-face consultations, there are some technical features or aspects we need to consider to make the discussions productive. We believe an acronym called TELE-PREPARED will be a useful one. T is for making sure that the technology is set up for connectivity, audio and video. E is for allowing extra time to establish rapport. L is for local support, including family members and health professionals. E is for eye contact using the camera and screen levels and ensuring that the emotions and facial expressions can be obtained clearly using zooming properties of the video conferencing.